is a huge honor today to be doing a podcast interview with a pediatric dentist, Jarod Johnson, who just put up a course a few months ago on Dental Town, The Blunderbuss Apex, a search for the smoking gun. What's all that about? Tell our listeners about your course and what made you want to do a course on that.
Well, it was actually interesting. So when I was interviewing for my residency programs, went out to Las Vegas and met Dr. Ron Lemon, and he's an endodontist. And we were sitting there in the interview, and he goes, well, you know what? We're growing new pulps in teeth. And I just thought, well, I'm a fourth-year dental student. I'm sitting here, and, you got so much going on at that point in your life, and you can't possibly know everything about every area specialty. I think we had maybe one hour lecture in dental school on teeth with immature apices, and I just didn't know if he was trying to pimp me or what was going on. And so I was kind of quiet about it. And then we got out to the program, and we just kept seeing these problems, whether it be trauma or caries with these immature teeth, and we were getting them sent from everywhere, and it seemed like there's just a mass confusion on how to treat these teeth. And in our residency program, Dr. Lemon would come down to our clinic and be the endodontist to work with us, and he's really changing the way that pediatric dentists in our training program were looking at these teeth. And I thought, that'd be something that we could expand on and help share. And he's been great. We've had a ton of cases that I treated there. Some of the other cases from the CE or from a few fellow pediatric dentists that trained with me. So it's just an exciting topic, and I think there's a lot of confusion that goes with that topic.
So do you mind giving away the low-hanging fruit on your course? I mean, I think it'll make people learn from it and want to go back and watch it.
Yeah, I think so. The biggest thing I think that dentists, whether it be general or pediatric dentists, that we miss is the diagnosis. And with the immature permanent teeth, there's a different way in diagnosing them. We have kids, for one, and they're not a reliable reporter. How many kids are going to come to you and give you the truth about their toothache when they're going to have it worked on, and you don't know their experience in the past? So it can really be a challenge sometimes getting the key information that you need out of that kid.
Do you
Parents
sometimes feel like a veterinarian?
Well, with the kids that have these immature teeth, we typically can talk to them, get a little more information compared to the primary dentition where they may be 3 or 4. But typically, someone at 6 or has a little better ability to talk to you and tell you what's going on. And then parents, they're not always with the kids. And if they have 2 different parents and they're living in separate households, one may say one thing, the other may say the other thing. And, your diagnosis based on, their subjective findings can often kind of be a little confusing. And then the way we do our objective findings too, the way we test or do vitality testing on the teeth, or sensibility testing is what the endodontists are like to calling it now, that can be tricky because the EPT doesn't work as well. So we may be relying on things such as cold a little bit more than the EPT, just because the last thing to grow into the tooth is actually the A delta nerve fibers, which makes the EPT work. So some of these things can get confusing and overlapping, and you may be testing an adjacent tooth, and that tooth's not as well developed, so that may not respond because the nerve hasn't grown in. So you really got to look when you're making your diagnosis to all these things, and it's just confusing because it's not always presented that way in dental school. You look at the teeth next to it in the quadrant, and sometimes you may be doing the opposing tooth, there's an adjacent tooth, or a tooth that developed at the same time as your control rather than the tooth that's right next to it. So, I think the biggest thing, we had some cases that would be sent to us from Reno, Nevada, and the patient would fly down and see us. They said they needed a root canal at their dentist, and we'd go ahead and do our tests and do our diagnostics, and it just needed a filling. So I think there's still confusion with these teeth, and it's not always easy to do either. Sometimes I was presented with challenges, and the only thing we could do to get a diagnosis was to remove all the decay, or work on the tooth without anesthesia, and that you don't want to be wrong with that with the kid. So those are some challenges that I see. In the diagnosis, we really cover a lot in the CE. I walk through some of it's very well evidence-based, the CE is. So lots of evidence to back up what I'm talking about, and just different tools to help you diagnose. And then we also talk about the management, and we go through vital pulp therapy, non-vital pulp therapy, regenerative endodontics, apexification, you know, pulp caps, pulpotomies, just all these things that are available to you to help you decide which way you want to practice with these teeth. We're trying to make it more clear so that you can manage these in your office, and it can really be a practice builder for you if you have a kid that comes in pain, and you can take care of that and you know what to do with it.
So Jarod Johnson, you're now you opened up your practice in Muscatine, Iowa.
Yep, that's correct. Pearl of
Iowa.
the Mississippi. So a beautiful town
It's on
here
the
on the
Mississippi
river.
River.
Yep, beautiful town on the river here, and we got a beautiful downtown. We got a lot of cool things that are coming into the community. It's got some large industry. We've got Heinz, we've got Han Corporation Furniture Manufacturing here. Monsanto is here, Kent and GPC. So there's a lot of good industry here.
Where were you born and raised?
So I was born in Lincoln, Nebraska, and then I've lived in Iowa City, Iowa, which is University of Iowa. I've lived there through high school, and then did all my college education at Iowa, and then 2 years out in Las Vegas, which is fun for residency and the specialty training to learn how to work with kids.
Did you spend more money in your pediatric residency in Vegas or in gambling?
Probably in the residency program. Tuition isn't cheap for students these days. I think the average dental student graduates with around $240,000 of debt, and that's average. So you're going to have some more. The private schools, they may be looking at a little higher education costs than some of the public schools. So it just depends on where you go.
Iowa is the most special state to me because I went to college in Creighton University, where the drinking age was 21, and if we wanted to buy a beer, we had to drive across the river into Council Bluffs, Iowa, where it was only 18. And I thought that was so silly that that Omaha and Council Bluffs couldn't agree on this because they have a policy in Nebraska 21, but just cross a bridge and it's 18. What's the point of having a policy? All you did was inconvenienced everyone to have to drive across a bridge.
Yeah, it's kind of like fireworks. We're next to Missouri and Wisconsin. They both sell them.
So what was that river? Count the bridge to from Omaha to Council Bluffs. Was that the Mississippi River?
That's the Missouri River. So
that's the Missouri River.
Yep. So
and you're on the Mississippi River.
Yep, other side of the state. So.
Okay, so you're almost touching Wisconsin then.
Well, Illinois. Yeah, Wisconsin
Illinois.
Also is a border state, but it's a little further north. So.
And how did you find that? Did you go there because there's the Iowa Fine Project where they'll give you $100,000 loan repayment if you go to an underserved community? Is that what you did?
Well, there's a few different reasons of picking the town. One was that both my parents and my wife's parents are in Iowa City, which is about 30 to 40 minutes away. And then also a pediatric dentist used to be here, Mike Canales. He went up to the University of Iowa, and now he works there. So we knew it would work. There's a huge need here for a pediatric dentist. There's a lot of underserved people, and I knew I could come here and be busy right away. One of the neat things I thought also that Iowa has done, and I think it could be a great model for around the nation, is they partnered with Delta Dental and the state of Iowa, and then communities around Iowa, and they are placing dentists in rural Iowa where there is a huge need for dentists. So through the university actually has someone that they hired to work and go out and help find communities that are searching for a dentist, and then work with students on the other side to help them, either open an office, join an office, and be in that community and serve. So through that program, I've applied for it. I haven't received the funding yet, but the community you go to also has to contribute a portion. And then you have to serve either elderly, children, underserved, 35% in your office. So you're helping out the community, serving the underserved, and then over a period of 3 to 5 years, they'll pay back some of your student loans. So it's really a great program to, get dentists to where they need to go. Because I think the way dentistry is heading, if we, aren't able to take care of these people that are in these small communities or underserved, it's just going to be more difficult looking at reimbursements from whether it be state insurance or private insurance companies coming in and running these state insurances. It's really going to shrink, and we're going to end up with a two-tier system like many other countries have. So I think it's a really good program. It helps with the debt that students are graduating with, and I know that's a big concern. And then it also really helps our health of our state. So I've been really pleased in working with Delta Dental, who's actually contributing a portion to it, and then the representatives from my community and the University of Iowa in helping make this program possible, because it's just a great program, and they've placed so many dentists into small communities in our state, and I think it's a great partnership for everyone.
I think that is so cool. I mean, I'm from Kansas, and 11% of the towns don't even have a dentist. And you know what? It's funny because you never go to drive down a corner and see 20 McDonald's stacked up on top of each other. But you go find a medical dental building with 20 dentists in one building. And then you drive an hour outside of town and there's a town with no one. And I think what Delta is doing with that is genius. Can you email me, Howard at Dentaltown, and CC the Delta guy? Who's the Delta contact?
Yeah, so the Delta contact, they have two different people working with it. One is Beth Jones, and then the other one is Susan. I don't know how to say her last name, but it's Susan, and they both are through the Delta Dental Foundation of Iowa. And this program, it's been around for a while.
Are they only do it in Iowa, or is there?
Yeah, so the state will give 25,000, and then Delta Dental will give 50,000, and then the community will give 25. The minimum you have to get is 5,000 from the community, but then that cuts back on the total amount that you get. So the community really has to have an initiative to bring someone in, and there's tons of benefits for the communities. If you think about it, what you're just talking about, if someone lives in that small town and they have to go to that big town to see those dentists that are like the McDonald's, they're going to spend their money there. They're going to go to lunch there. They're going to shop, buy their groceries there. You know, all this travel and out of town is going to take money out of these smaller communities. And it really hurts other businesses when that money that could have been spent in the community that you live goes out of town for specialty care, whether it be medical or dental. So I think the plan can work for other professions as well, just to help business in the communities. And then, you know, the dentists are obviously going to be good employers. It's going to be stable for a lot of families in there. And, you know, it just really helps having a dental provider in the community too for oral health.
I can't tell you how many dentists I can tell you had this story. They wake up in their house where there's a dentist for 1 to 2,000. They commute an hour into work where now they're down to a dentist for every 500. And they're an hour in traffic every day listening to my podcast. And then they do that, where if they would have got up in the morning and drove an hour the other way, they would have driven to a town of 1,200 people without a dentist. If you drive to that town, I can't tell you how many dentists found that town, went to the mayor of that town, and they go to the corner of First Street and Avenue, and there's, you know, half the buildings are boarded up. And they say, well, see that red building right there that's 100 years old and boarded up? If you give me that for free, I'll put a dental office in there. And they're like, hell yeah. And then, so now they got a free land and building. And then they'll sit there and say, well, I have too much student loan debt. I can't afford a loan. And then they walk you to the only banker in town. He's like, you're going to live here. You're going to work here. I'll give you a signature loan. So they get a free land and building. They get a signature loan, and they open up their practice. Then they find out that they're doing $1 million in that small town with very low costs and overhead and netting like 400 instead of driving into downtown. So it's just, it's a demographic nightmare in the United States. These young dentists go out and they make this one little wrong decision, and that is to go to right downtown, big city. Nobody needs you. Nobody wants you. You're not unique. And then they suffer there for 20, 30 years. And just that one little decision was such a game changer. That's why I send Beth Jones and that Susan. I bet you anything her last name is Q. Is her name Susie Q?
No, I don't think so.
Is she singing a song, Susie Q, when she's starting? Is she? But yeah, I want a podcast, and I wonder how many states Delta does this with.
I am not aware. So if you go through the ADEA, the American Dental Educators Association, you can actually get on their website. If you're a young grad right now and you're looking for some opportunity to help pay down your debt, they have a state-by-state breakdown of the loan repayment programs that are offered in the state you may be wanting to participate in. Could be something anywhere from Indian Health Services. It just depends on your state. And I've just been really impressed with what Iowa has done, and, you know, it's working. You know, every year there's money appropriate. There are 4 spots this year available for 4 people to get this, and you know.
And how many took it?
Well, I don't know what the final numbers are, but I'm just waiting on my community match fund. So that
website is ada.com or .org?
That's ADEA, so it's the American Dental Educators Association, and
But
they have a list
but is
of.
it ada.com or .org?
Let me check here. I can see if I can pull it up. I think it's adea.org, maybe. Let's check. Yep, adea.org. So that's the American Dental Educators Association. It's different than the ADA, but it's an
Is it part of
organization.
the ADA? Is it at 211 North Chicago Avenue in
No,
Chicago, or where are they out of?
let's this one. I'm gonna have to check here. It should be on their website here, I guess. This is in Washington, D.C. So
Washington
this
D.C.
is like, if you're a dental educator, this is their association, for
Who's the executive director of that?
I'm not aware, but they just put the list on. It's, it helps the students with, anywhere from getting into dental school to placement after dental school. And it's for dental educators, it's their big organization. So if you're a professor, an adjunct at one of the schools, you can be a member there and help partake in that organization.
That is amazing. And also, and dentists can just start driving to these small towns and these cities and see what's available. I also think a reverse engineer. This is what the founder of Heartland Dental Care, Rick Workman, did. Is he was so counterintuitive. He just started calling the insurance companies saying, where are you selling insurance across the whole state? But people are calling up and complaining, say, I have your insurance, but there's no dentist. And they literally gave them a list of these are the towns we get complaints that I have insurance for the state sheriffs, police, teachers, firemen, whatever, and there's no dentist that takes my insurance because there isn't a dentist. And he started going there and opening up dental offices. So he worked with the insurance companies backwards to find the location. I mean, that's just genius.
When I was down in my training in Las Vegas, I had the opportunity to join the Southern Nevada Dental Society. And, I love being on Dental Town. I check it probably every day, and it's great. And I got a lot of ideas for my office on it. You pick up little things. In dental school, they don't teach you how to fill out an ADA claim form, as silly as that may sound. You don't know how to file insurance. What do you do with primary and secondary insurance? All these questions. A lot of those topics are covered on Dental Town or covered in the magazine. And, as a young professional, it's great to have that community online to be able to see what other people are doing. Maybe you don't comment on every post. Maybe you're just browsing it to look at something, do a search of something you really need an answer on. But one of the things it doesn't do, it doesn't bring a lot of policy together on the state level. And that's why I got involved in the Southern Nevada Dental Society. And you would be surprised some of the things that are just going on in different states and in Nevada alone, things that, we're fighting as dentists. And one of the things I think that's interesting is most dentists go in and either, join a practice or join a corporate practice. And these corporations, whether, I'm not saying they're bad or good, but they're not coming to the table at the state or at your dental meeting as a delegate and talking about these issues. And we really need to stand up for ourselves as a group, whether it be, code bundling. I'm sure you see that every day in your practice, and it's okay for the insurance company to bundle all these codes together, but it's not okay for, a dentist to do it. So
What do you mean? Explain that. That went over a lot of people's head. What do you mean code bundling?
Code bundling is, let's say, I have a patient that comes in for a new patient exam, and I do 4 bite wings, and then I see a few teeth with large cavities. I want to make a few PAs, and then I don't want to do PAs of all the mouth. I want to get a pano on this young kid to see how their teeth are developing in their jaw. What they'll do is, instead of paying for the pano, paying for the bite wings, and paying for the PAs you made, they'll bundle that and say, nope, our FMX, or Full Mouth Series, Complete Mouth Series code is more cost effective for us to pay that than to pay for what you actually did. Whereas if I were a dentist and I submitted things, that I didn't do, that's fraud. But when they bundle it for something I didn't do, that's okay. And it's just not fair for us not to get paid for what we do. We talk about the debt levels, average graduate over $240,000, and you got to be able to produce that money to pay that back. There's going to be a point where we're not getting paid enough to take the insurance plan. You're going to have the problem we just talked about, where nobody in town's taking my insurance because, these things are happening. And we spend a lot of time, and without the x-ray, we can't really diagnose. And there's other things when you do a crown or look at direct pulp caps, for example. if you're doing a direct pulp cap, looking at some of the recent studies with MTA and 80% success. If you could avoid a root canal 80% of the time in these cases, shouldn't you get paid for that? An MTA is not a cheap product to have in your office. It's a lot of cost associated with it. It's difficult to handle. It's going to take you more time than putting calcium hydroxide on there, but it's better. And if you can avoid a $1,000 root canal on a molar, I think you should get paid for it. So there's a lot of things that they bundle in, and you know that they are services, and we do have an overhead cost, and we do have to provide for that. And if they're bundling these codes and we're not getting reimbursed what we should, it's going to be difficult for us in the future to go forward and offer quality care to our patients that have insurance.
Well, speaking of overhead, have you heard of the website Physicians for a National Health Program, www.pnhp.org, pnhp.org. It said a health insurance company CEO's total compensation in 2014. The head guy of Cigna made $27 million last year. That's $104,000 a day. The head guy of United Healthcare made $66 million. That's $254,000 a day. So the average dentist walks out of dental school, student loans with about $250, and this guy makes $250 a day. The head guy Humana made $13.1 million last year. The head guy of Anthem made $8 million last year. That's $31,000 a day. So yeah, it's tough because everything intelligent is about checks and balances, and if you didn't check the dentist, they would want to come into work on Monday morning, do one crown for $1 million, and then go home. And the insurance companies, they had it their way. We'd all be indentured servants. You know what I mean? So it's always that checks and balance. Can the lion really lay down with the lamb? So they have to be checking and balancing it, and it's complicated. You got the government, you got the dentists, you got the insurance companies, you got the patients, and they're always edging, back and forth.
Yeah, it's definitely something but that's some of the things that in Nevada that they're working on to, have someone that reads some simple things like someone that reads a claim should be a dentist from the insurance company. You shouldn't have someone that's not a dentist saying whether or not this crown is justified or not. That should be a dentist. So there's some little things that they're fighting for dentists, but we also need as young dentists to, be at the table and be invested in these things, or, we need to go for it and take it on a level as we're advocating for the patient, because that's the only way that we're going to ever get anything done is if we're out there and we're on the patient side. And I don't think anyone went into the field of dentistry to not take care of people. You never hear anyone say that when they talk about why they became a dentist. So we're in a unique profession where we get to be our own boss right now, and I like to keep it that way.
We got to what?
We get to be our own boss if you choose to.
Oh, be your own boss.
Yeah, and I think that's appealing for the field. And then we're also in a field where if someone comes to us in pain, we can make a difference in their life, right away. So there's a lot of things that are attractive about dentistry, and if we're not at the table and leading on the forefront in our organized dentistry, I don't think we'll probably be a lot of corporations. We'll probably be like the pharmacies where we used to have a CVS. A local pharmacy. Now we have a CVS and Walgreens, taking over. So we definitely need to be involved, and I agree there's some, give and take, but if we're not out there trying to work with them and, advocate for our patients, I think it's going to be more difficult in the future as, we aren't our own boss and we kind of do what we're told.
I think specific to your CVS deal, the problem with the pharmacists is that 70% of their cost was buying the pills. And so that's a perfect economic model to roll them all up so they can all have leverage against Merck and Pfizer and Johnson & Johnson. Whereas in dentistry, only 7% of our cost is supplies. The pharmacists were 70%, and we're only 7% for supplies. So I think, and then number two is that a pharmacist just hands you, a bottle of pills.
Yeah.
You don't care if a Obi-Wan Kenobi or R2-D2 or a droid or an ATM machine hand you pills. But in dentistry, the reason I think it has the most safety is I don't see any dentist holding on to even half of their patients. I mean, they get 25 new patients a month. their whole life. And if you got 25 new patients a month every 3 years, 25 times 30, you'd have a full-time hygienist working 40 hours a week, 50 weeks a year, servicing 1,000 people for 6-month cleanings. And they'll get 25 new patients a month for 40 years and still have one hygienist. It seems to me that for every person that walks in a dental office front door, one works out the back door. And at 2015, nobody can keep their customers for life. And so, so who cares if it's a corporate dental office across the street or a private practice? You go the practice across the street. If it doesn't matter if they have no hygienist, one hygienist, or two hygienists, or three hygienists. Come back 10, 20, 30, 40 years later, their capacity never changes. So some will just like build $1 million practice and they'll do $1 million a year while getting 50, 60 new patients a month. But they'll get 50, 60 new patients a month for 4 decades, which means 50 to 60 patients a month were going out the back door. And so I feel at 2015, when you lay a person back and you have to work with your hands in their mouth and you got to explain this Latin and Greek to a patient who doesn't know Latin and then pay money, it's so stressful and it's so complicated that nobody has figured out how to keep even half of their customers for life. And so I don't think so. Corporate dentistry, I don't see any advantages they have other than a group practice where if 2 people shared a pano machine, it'd be lower cost than if 1 person has. So other than just the raw scales of efficiency of a group practice, like I've always had 2 or 3 dentists in my office to share that so we can expand hours on it. But I don't see any advantage corporate dentistry has over just my practice that has a couple doctors. You know what I mean?
Yeah, I definitely see. My point is more along the lines of, we want to be involved in organized dentistry to go ahead and make sure that we're really addressing the issues that are concerns to the dentists and, and to our patients. And I just want to encourage people, it's great. You get to meet people and you get to talk to them, network with them, similar to like you do on Dental Town. But you're also doing something in a different way than what we do on Dental Town. Dental Town's more, talking about issues that come up in our everyday practice, talking about techniques that, people are using that are great ideas out there. I've learned so much from just being on there, but I'm just trying to be an advocate for, things at the state level, things that are going on in each of the states. So that was more my point. It's not the point that, I don't think corporate's bad. I think, it is what it is, and it's going to be what, it's a great stepping stone for some people. And, there's corporations out there where you can own too a portion of it. So I think
what percent of the dentists are members of the American Dental Association?
So I believe the last number I heard, I don't know if this is true, but I think it was over 90%. So
for your state of Nevada or Iowa?
I'm not 100% sure. I know Nevada, when I was in Nevada, that was always a struggle, trying to get people in, and people don't necessarily see the benefit, but there's a lot that is being done. And I honestly didn't see the benefit till I was a delegate and I was sitting in the meetings where we were talking about the issues that our lobbyist is going to town for us on. Like some of these issues were, big deals, and our dental association, we were taking steps ahead of the game so that when legislation came through, we're proactive. One of the things was with opioid abuse and having the system to look up opioids on your patients and, do a self-report on that. And you could look that up. And then the medical profession, they weren't ahead of the game doing that. So when the vote came up for the law, we were already saying we're already doing this. And the medical profession wasn't, and it was kind of a big deal to have.
So talk about specifically, you wanted to be able. So explain the opioid abuse website. You want to look up information. What do you mean?
So what the Nevada Dental Association is, they actually worked with the Nevada Dental Board to go ahead and make it so dentists had to log into the system, and it's a system where you could check, if you wanted to, how many times the patients received a narcotic, so you could see, just differentiate between.
So it would tie you into Walgreens and CVS's data bank, so you could see this patient, Frank.
You could look something up, and then, it also would provide, information so that, you can look for things that might come up if there's a red flag. And it was just, there was already legislation coming down the pipeline that was going to regulate this, and it was going to be way more regulation than what the dental association had, and it was enough. So they were proactive about it, and when it came time to go to the lobbyist went up there and said, hey, we're already doing this, look at all the positive steps we're doing to help reduce opioid prescription abuse in Nevada, from dentists. Everyone thinks dentists are these huge prescribers of opioid, and this was one way to combat that and just say, hey, this is what we're doing to, make sure we're proactive about the patients that we're treating, looking them up, and, having a resource for dentists to do that. So those are kind of things that you don't see that if you're not sitting at the
Yeah.
table talking about.
Interesting thing about hydrocodone, it's been the number one most prescribed prescription ever since they started recording prescription. I mean, every year I've ever seen, here's the top 10 prescribed medication in the United States. Hydrocodone, zero point 0.5 milligrams, 500 milligrams of acetaminophen is number one every year. But you know what? I used to do is when I got to school in '87, back before computers and all that stuff, and we had prescription pads. I always wrote the prescription pads for the pharmacists. I went to Walgreens and CVS and invited every single pharmacist to my house for dinner and got to know them all because so many people go to the pharmacist and they say, what's good for toothache? Is it this Oragel or this Dill, whatever? And they would peel off a prescription and they'd hand it to them. And then later they told me that their general managers found out and that they're not supposed to do that, but they all did it anyway. And then when I would ever call my pharmacist friends in Ahwatukee that I'd had for dinner at my house, and I could just say, hey, patient, Jim Jones, is he pulling my leg? And they'd say, dude, he's got a prescription for Vicodin from 16 different doctors in the last 90 days. And then so and I think all that's illegal, isn't it? I mean, for him to tell me that, is that illegal?
As far as the
HIPAA violation? Yeah, the pharmacist. I mean, when I call my pharmacist and he tells me, no, dude, this guy's working the system, he's abusing.
Well, they're involved in your patient's healthcare. So if you, with your HIPAA protocol in your office, if you're allowed to, my policy is written that if we need to get information that share with another medical provider, we can get permission to do that. And some of these, Iowa has a database as well that I'm aware of. I haven't.
So when your patient signs the HIPAA deal, that gives me permission to call the pharmacist.
Well, it depends on how your policy is written. If you're able to share
you should start a thread on Dentaltown and get everybody posting their HIPAA deals so we can all read through them.
My HIPAA, it's a huge one, but it's through the ADA. It's kind of interesting with the HIPAA stuff. I went over to an urgent care here because I had wax in my ear, and their HIPAA thing was like 2 sentences. And I just thought, how are they getting away with this when I got to have 4 pages of stuff? But I think it also depends on your state and then the way your form's written. If you have it written so that you state that you can share information with these providers and they sign that form and agree to it. Obviously, then they've given you permission to share information. If your policy is not written so that you can share that information with them, maybe you need to get some more permission depending on the provider. So
you know what? I'm a big fan. That was the reason I contacted you. You have 400 posts on Dentaltown. You got a CE course. I'm a big fan of your posts. Do you think you should start a thread on that? Post the ADA HIPAA form?
Well, so I paid for it. So I don't, obviously, you don't want to be using copywritten material, but if you go to the ADA's website, you can actually purchase the OSHA compliance manual and the HIPAA compliance manual. And I did both those as I opened my office here.
So ada.org, the / www.ada.org.
Yep, and then it'll be in their catalog. And then make sure you look, if you're an ADA member, there's always sending you something in the mail. Make sure you get the coupon code because you'll save 10% off of that. So don't pay the full price. I mean, it's going to be reduced anyways, but then make sure you find a coupon code because they're sending them out all the time, whether it's through the ADA Morning Huddle or if you're getting it, they'll send out brochures to you sometimes in your office to try to get you to buy those. But usually there's a promo code. So make sure you get the additional % off. But I use that as I started my office. And
you said the HIPAA manual and the OSHA manual?
Yep, I actually bought a bundle. It came with the HIPAA manual, the OSHA manual, and then dental letters. So press releases, stuff for your website, dental letters when you got patients that aren't showing up, dental letters when you got patients that have care they need to get completed.
How much was all that?
I think it ran me around $800 to $900.
Wow. Do you know the person in charge of that?
I do not, but it's through the American Dental Association.
Yeah, and talk about their morning huddle.
So that's
The
something
morning huddle, the email,
Yep,
the
the
newsletter.
email is something that
Yeah,
I've been impressed with.
so have I.
What they do is I think they have a system where they can scour press releases and newspapers from around the nation, and I think it's really good because I've actually used some of the articles they put there in my social media. You know, you're always looking for an article or something to put out, and it's about probably 10 to 15 articles every day that they send out, and usually it's something about a public health measure that's going through, someone's doing dentistry from the heart, things like that, that they're opening their office for free dental care. An article with the world leader in, dental care in their field, so like a specialist. They've had the AAPD president on there, the ADA spokespeople are on there. And it's been really good because you can pick out a topic probably every day and share that on your social media if you wanted to kind of help educate your patients and really have a presence. I always like the stuff that you post on your stuff, and some of that stuff I share too um, on my social media. But this is something that, it gives you an idea of what's going on in the dental field. What are some issues other states are dealing with? What are some things that are coming up, as far as patient concerns? There may be an article in the Wall Street Journal that you can, take a look at and see maybe one of your patients reads that, and maybe you need to know a little more information about it. I think there was just one, 2 or 3 weeks ago that was great on sedation. And if you do sedation in your office and you had a patient read that, they may be coming to you with some questions, about your monitors and what medications you're using and what are some side effects. So, reading that, you can really be prepared when the patient walks in the door and, they tell you, oh, I read this article, and you'll know exactly what they're talking about just by reading that little short paragraph for probably a minute of your day. And if there's something interesting, you click on it and read it.
I love your passion. I love your enthusiasm. I just love everything about you. And why would you come out of dental school 200, 300, $400,000 in debt and not invest $1,000 a year in membership to the American Dental Association, which is your organized body for representing dentists? I've been a due paying member every single year since graduation in 1987. And it just irks me when you hear dentists bitching about the ADA so they don't pay their dues. It's like, well,
They
you bitch about your country.
they do so much for us. It's just that we're not. If you're not involved in your local dental association, or if you're not in these committees, you don't know what they're doing. They're
I know.
distant to you, and they really. My eyes were opened in Nevada. I'm lucky they asked me to be a delegate for the 2 years that I was there. I made great friends, great mentors I met that were in my state, and they do so much for us. And I think that sometimes if you're not involved, you don't really appreciate it. But what other body can go to their nationally and say, we've got 90% of dentists in our organization? That people listen to that. And if we ever lose that, and we have, I think, the American Medical Association, I just saw how they don't even, I don't think it's even half from
I
what I
know
saw.
they have under half. They fell under half a decade ago.
And we as dentists, we have this ability, and people will listen when you say, you walk into that senator or congressman's office and you say, I represent 90% of the dentists in America.
And you're right.
That's powerful.
I had dinner last week with the executive director of the Arizona State Dental Association, Kevin Earl, and his number two guy, Terry Zalowski, and it's mind numbing to hear all the things they're working on. And you're right. You have no idea. I mean, you're in your office and you're trying to get number 19 numb to do a root canal, and you're just worried about your rubber dam clamp, and they're talking to all these legislators, all these issues, all these things, and you don't know the half of the details. And then dentists might hear of like a low hanging fruit, big macro question, but it's 80% of the stuff they're working on you never even know, and it's so important, and we have to have a collective body voice,
Yeah, and if you're young, and one of the hardest things for me when I went to the meetings was, I'm a new dentist, I'm a nobody. You have all these dentists in the room they're buddies for 20 years, and you're trying to, get in and talk to them, but don't be intimidated by that. Go to a few meetings if you can. Talk to people. People are going to start to realize you when you show up. That's how I was asked to be on this committee. I showed up to things, and that's what people want. And once you start showing up, you're going to make great relationships with the people in your community. We're all similar, but we don't all go there and we talk about dentistry, but we talk about our families, and they're great friends. It's just relationships that you'll build are incredible.
And I love the president we just had and the one next year. Did you see that podcast with those? It was, what's her name? Maxine. That's president of the ADA. Just finished, and then the next year is from Southern Cal. I mean, just great people, just great, honorable, good people, just trying really hard to do the right thing. I mean,
Yeah, I
just
can't
love them.
imagine that'd be a tough job to, have all the speaking obligations that they get to have, and you're the head of talking for 90% of the people. It'd be pretty stressful. And there's topics that keep coming up. I remember the infection control one where you had the dentist in Oklahoma that had infected some people from reusing the same needles. The fluoride stuff that's going on, amalgam. All these things are just things that they constantly have to have the talking points right on for us as an organization, or we could be in a world of hurt.
Yeah, yeah, and the sterilization thing, I have a feeling that's going to go down really, really ugly because the the dentists I've known at the Centers for Disease Control for the last 28 years and getting information about water fluoridation, all that stuff, they already have had epidemiological models where they've traced back outbreaks of, like, say, hepatitis or something, and just it all pointed to a dental office. And this, I know this Cecil Lion. How do you connect Cecil Lion to this? But
Yeah.
it's the same thing. It's a perfect storm. There are already these big groups forming that did not want big game, and they were forming and getting bigger and louder and louder. And then a dentist walks in, a rich dentist from a rich country, and shoots that lion, and they were just ready to destroy this guy. And the truth be known, that a lot of people in that country didn't know who Cecil the Lion was. It wasn't made out. It wasn't like
Yeah.
but and the next, and so he was in, part of a perfect storm, that the world's had enough of shooting lions and rhinos and
Yeah.
zebras. And the same thing is about to happen with sterilization. I mean, for years, did you see that peanut butter guy who just got sentenced like 28 years because of a food poisoning outbreak? And and groups would always say, well, how come if an individual goes and shoots a guy, you press charges? But when a company isn't doing the right thing and they kill 10 people in a food outbreak, you don't even press charges. So all these groups have been raising for years and years and years, and finally they had the peanut butter contamination, and the feds went in and they investigated it, and they tried him like it was a murder, and the guy got 28 years. And that's going to
Wow.
happen to a dentist. A dentist, a good old boy who just wasn't running sports, had just, thought, bought a nice deal from their dealer and thought everything was great and thought their assistant was good, but really didn't do the details. And then there was going to be some type of little, like a hepatitis outbreak, and someone's liver is going to shut down and they're going to die. And the media and social media is going to pounce them, and they're going to put them in front of a jury, and they're going to show, due to you not dotting the I's and crossing your teeth while being a rich dentist making 150,000 a year, little poor Amy's dead. And a trial is probably going to send that dentist to jail. And that's probably what it'll take before everybody sits there and says, you know what, in this world of instant information and social media, it's game over. You got to dot the I's and cross the T's,
Yeah.
or go home or go work for corporate or the Navy or someone else.
Yeah, and I agree with you. And that's one of the things. How many of us in our dental school training got in front of our mid-mark M11s, were taught how to load it and do all this stuff? It's not, that was never taught to us. All the instruments you use in dental school, you put on the tray, you send off back to the big central sterilization, and you never learn that process. So, there's tons of things that we don't learn in dental school that, if we're going to be a business owner and we're going to be taking this risk where we do need to sterilize our instruments, we need to make sure that they're clean and, know all the protocols to make sure that we keep our patients healthy. We definitely need to be able to get that information from somewhere. And, it's great. When I open my office, you have the reps come in and you get your training, and then you run your spore tests and you make sure things are going right. But that's something that's not taught that we have to be aware of. And if you're not savvy enough to pick up on these issues and, make sure you're dotting the I's and crossing the T's, you could be in a lot of trouble.
You know what's weird about my autoclave is whenever it gets loaded, it starts using profanity and repeating the same stories over and over. A pun on the word loaded. Horrible joke. Okay, and so what's the difference between the dental society that you were involved with in Nevada versus Iowa? Is it kind of the same, different issues, different?
So some of the issues, I think, are the same. It's just that they're at different points within the states. I've been to one meeting here in Iowa. Las Vegas is a big community. It's their dental meetings. They have them every month from August all the way through the end of the year through March, and just a lot more meetings. But as far as the dental societies, there's different issues. So Iowa's currently undergoing Medicaid reform, so it's going to go from state-run to private-run. So that's one of the issues that dentists are facing. We've had a lot of companies come to us say, I've got the deal. There's no deal that's been made, and they're trying to sign you up. So when they go to the state, they can say, we got all these dentists sign up, pick us. So there's different issues that we're battling in different states, but I've been impressed with the people in my district meeting, and I've been to a few of the Iowa dental meetings, and it seems like our delegates and trustees are trying to work on the issues that are really pressing to dentists and our patients in the state. If we have some of these private companies come in, take a skim off the dollar, some of our fees that we're charging doesn't even cover our lab fee. And then you're going to take more away. How are we going to be able to see some of these patients that have, the greatest need? It's going to be a little more difficult. So we need to advocate for our patients and make sure we're getting reimbursed properly to at least, cover our fee, and then we got to pay our staff, and so that's got to happen. Otherwise, we're not going to be able to continue to see these patients, and it's going to be an unfortunate circumstance for a lot of people, including the dentists.
Now, when you were in Nevada at the Dental Society and now in Iowa, did you guys have like a Dental Town message board to talk all the time in between going to the physical meetings where you see each other?
So yeah, they're not quite. That's one of the things I like about Dental Town. I can log on every day and
because
see.
you do you realize on Dental Town we spent a year programming private forums. So there's the complete Dental Town. If you go to private forums, you have a complete Dental Town where a guy can start a group and they can add or not accept or kick out members, just their own Dental Town. So you could go to all the dentists in Iowa and say, I set up a private group on Dental Town and we can all talk, and no one can go in there and read what we're saying unless the person who started the group accepts them or denies them. And I set that up so that all 50 states, they could go in there and talk about these political issues without having to worry about other people reading what they're saying. Were you aware of the private group section?
No, I wasn't. So Nevada had one that was a Facebook group, but obviously, different generational things. A dentist that's been practicing for 50 years may not be computer savvy, and one that just came out of school maybe. So there's, obviously it's a great way to communicate. And I think there were a lot of things that were brought up on there about trying to get people to come to meetings too. Different topics. If someone was doing an after hours at their office, or they wanted people to come over and just talk. That was advertised on there. So I think it's definitely got a good place. And I love that idea, just having another private place, because sometimes on Dental Town I'll read something and I'll say, I don't know if I would have written that if my patient could read that,
Right.
Because obviously there's issues and no one's mentioning names and we're all being very compliant as far as HIPAA. But if one of my patients got on there and read something that I had wrote, I'd want it to look at me in a positive way. And I know we get frustrated sometimes, but definitely want to always have a positive spin on my name and the things that I say. And it's nice to be able to have that private way, so that way. Or if an insurance company were to get on there, or, someone that was against the, of agenda of advocating for the patient, you definitely wouldn't want to give away all your tips and secrets if you're going to work with a lobbyist and trying to pass legislation.
So let's go to pediatric dentistry. A lot of kids that listen to this podcast are juniors and seniors in dental school, and one of the biggest questions they ask when they graduate is, should I do a residency or should I specialize? How would you answer that question, and specifically towards pediatric dentistry? Why did you pick to go on to pediatric dentistry instead of being a general dentist? And was that a good decision, and would you do it again?
Oh, I'd wholeheartedly do it again. So when I was in dental school and in my college training, I was able to work with a few organizations that I was actually a junior high football and basketball coach. I worked with a few organizations that worked with kids in town, and I realized I could deal with the older kid or junior high kid, and then also through dental school, it was just fun working with the kids. Every day I come to work, and it's going to be different. No day is going to be the same. You never know which personality of the kid's going to show up, and really to treat kids. I felt like I needed to have specialty training to be able to offer, either a sedation or go to the hospital, to try to make that kid have as positive of a dental experience that I can. And one of the big things, if you're looking at pediatric residency programs, I would definitely look at what their what their school's philosophy is. Are they a hug 'em, are they a drug 'em, or are they a slug 'em school?
Oh wow, I've never heard of that. Hug 'em, drug 'em, or slug 'em.
Yeah, and every school's got a different philosophy. The hug 'em schools, you're going to praise them and work with them. The drug 'em, sedation heavy schools, so you're going to get a little bit more work with oral sedations and maybe some IV sedations and then anesthetics. And then, the slug 'em school, you're going to get more behavior management. And what was
Slug 'em is okay. So hug 'em is more
praises and you happy and friendly, and then slug 'em, you're going to get a lot more behavior management with them as far as getting things done, and maybe a little stressful on you, but at least what it's like. I think you should experience all of them in your residency. Take the most difficult cases you can, because once you leave, you're on your own. You're the top person there. There's no one behind you to step in and say, what are you doing, or to take over. You really got to be confident once you leave your program, and I think anyone that goes into a specialty program will be. But definitely take the most difficult cases you can take, and ask about the philosophy. If you really want a sedation experience because you think you're going to do a lot of sedations, don't go to a slug 'em school where you're not going to be able to get that. And then also you're going to want to make sure you go to a school that ask them what drugs they use. You want to be versed. If you're going to do a lot of sedations, you want to be versed in a wide variety of medications and feel comfortable doing that. You don't want to get out of practice and say, oh shoot, I didn't train with this drug, and then think, well, should I use it or not? My answer to that question would be, I'm not going to use something I haven't trained on, because if you haven't trained with it, you might not get all the things that you need to know about it to be comfortable with it. And so those are definitely things. You obviously want to look at what's your call schedule like. Definitely you want to be able to deal with trauma. You want to be on call and be able to deal with those things. So when you see that in private practice, I know it sucked being on call, but when you got to go into the hospital and take care of someone and you were the only person there to do it, you learn pretty quick on how to manage these cases with trauma. And trauma is difficult because it's not always going to be successful what you do, but at least you can know that you're able to develop the best treatment plan at the time, and given the course of the patient's follow-up, you be able to see them, or they'll follow up with their regular dentist. But you can make a big difference in someone's life, and if you can be able to deal with trauma.
So if you saw 100 patients, what percent of your tactics would be hug 'em versus drug 'em versus slug 'em?
Oh, it just really depends, on the patient, and obviously parents too these days. Parents are becoming more and more, they don't want their kid held down, and then parents that are very affluent, they don't want their kids to have drugs. They think they should be able to do it. So depending on, the parent and how much work they have, the amount of time, if the kid comes to me in pain versus if they're not in pain. I think there's a lot of talk that's been going on about this, the silver nitrate and silver diamine fluoride as alternatives, the Hall technique in pediatric dentistry. There's a lot of different things that we don't know a whole lot about, but are definitely alternatives to doing things. Maybe if we can kick something off a little bit further, the kid can grow and we can get it done in 6 months. I don't know. It just depends on every kid. I try to look at every kid as an individual and see what's going to work best for this parent. Is this parent going to want to have their kid sedated? Are they going to want to just get put to sleep the whole time? Sedations, it could be multiple visits, and maybe they'd rather have it done at once. There's risks to both. There's benefits to both, and that's probably the thing I've struggled with the most being out in private practice is, trying to come up with what's going to be the best behavior management technique, because one technique doesn't fit every patient and it doesn't fit every parent. And at the end of the day, you got to have the parent happy and the patient treated successfully, or that patient could be going somewhere else.
Oh,
Go
sorry.
ahead.
No, go ahead.
One of the big things I learned in residency, and as starting as practice, that's been great, is when the patient comes in to you in pain, or the kid comes to you in pain, and the parent's taking the time off work, it's a great benefit if you can get that treatment done. So when they go home, they're not in pain, because when they go home and their dad's sitting there and the mom brought him in and that kid is still in pain, they're going to say, you went here, you took this much time, you didn't go to work, and you spent this much money, and they didn't take care of your problem. It's going to create some problems at home in the household. So there's different, ways we can do things. Sometimes, you can't always do treatment, and sometimes it's difficult for the parent, or the patient, I should say. But definitely, those are kind of things that I like to take into consideration. And sometimes it's challenging, and sometimes they don't want to do it, and you can't really force anyone to do anything. You can just educate them on what is going to be the best for their kid.
So, is there still a use for a papoose board in your opinion?
I believe so. So there's different uses for it. A variety of reasons. So it may be to, help you get the procedure done where you've got a kid that may be going to the hospital, if you don't do this. That could be something where, the infection or the pain is that bad that it has to be done. It maybe need to be done on a sedated patient. Someone that is sedated, they can't, they're flopping around a little bit. They just need something to hold them down a little bit so that they're not interfering with your staff or the procedure. Obviously, we're using sharp tools, instruments that can get in the way, and then some special healthcare needs actually do benefit from utilizing it. So things like autism, if that's something where the patient's going to feel more comfortable when they're in a blanket wrapped up, that may be something where it can be done. And then there's some times where the kids, anesthesiologists here in my town, they don't want to take a kid under 2 to general anesthesia. So, if there's a kid that has D, E, F, and G and they're not looking so good, and, I'm not comfortable sitting here, that may be, our only option to get those teeth out. They'll be numb, but sometimes it has to be done, and, that's something to talk to the parents about. There's risks to going to sleep, and on a 2-year-old, I think we're finding out more and more about general anesthetics, and there's been some posts here on Dental Town even discussing it about general anesthetics and young kids and neurotoxicity. I don't think we know the answer. I don't think we have enough information to say one way or the other, but like you said, in this world where social media, if someone can pinpoint something on some procedure where there's something, a risk or something, that can be a big deal. So,
By the way, do you spell papoose board with a PAP hyphen POSC, or do you just go PAPPOSC?
PAPOOSE is no hyphen. That's how I've had
PAP.
OOSE.
Oh, so it's a PAPOO.
I
Okay.
think that's how I've been.
You're incredibly intelligent, because the dead giveaway red flag of a highly intelligent person is there's no black and white yes no answers to anything. Everybody wants a yes no, left right. Just say, and life is 50 shades of gray. And when someone comes in and says, "Oh, amalgam should be illegal and there should never be papoose boards," I mean, they're just not critical thinkers, because, like you just said, if you don't get it done and you have to get it done, the next step might be, an emergency.
The hospital.
The hospital.
Look at the kid. I don't know if you've heard of DeMonte Driver's story. DeMonte Driver went into the hospital with a toothache. His mom left. She came back the next day, and he was dead. He had bacteria from an abscess tooth.
How old was he?
Going to his brain. I'm not sure on his age, but this was a while ago, and this
Right.
is,
It was all over social media.
if he would have had that done, he'd be here today. And there's times where maybe, yes, I would use it. And it's not every time, but
What about nitrous oxide? Does that fall into your drug-em category? Is
Yep,
that
so that would
under the hug-em or drug-em or slug-em?
that'd be a drug. So that's just like a nitrous oxide has been shown to be safe and effective. It doesn't, work
Do you use it much?
Yeah, quite a bit.
Quite a bit. Like what? But you don't like to give percentages. Like what percent would get nitrous versus what percent would get sedation versus what percent would get a papoose? Just in general, because guys like me aren't a pediatric dentist. I'm just curious.
Sometimes the nitrous is more on the parents. I don't think the kids need it, but it does help relax them. It hits the brain in 3 different receptor areas. One of those being the opioids. So it can help with things like the injection, smaller fillings on certain kids. I might not have to use an injection. It just depends on the kid and thing. I can't say it's a blanket at all. I know you want a yes or no. It just depends. And I probably would use it. I probably use it on probably 60% of patients.
60%.
Then I also use it when I do my sedations. So.
And when you do your sedations, are you doing it in your office or do you take them to the hospital?
Yeah, so sedation is in the office, and then general anesthesia is done in a hospital setting. So sedation, we're doing moderate sedation. I have a moderate sedation permit here in Iowa. It means a purpose response to a verbal command. They're awake the whole time. If I ask them how they're doing, they'd be able to say yes. Or, sometimes the sedations don't go well and they're just screaming. And at that time we discuss with the parent if they want to go to the hospital or they want to finish what we're doing at that point in time. And then
What terminology you said sedation you do in the office, and what do you do?
moderate sedation.
Moderate sedation do in the office. Then what did you call it when you take them to the hospital?
That's general anesthesia. So
okay, you call that general anesthesia.
Yep. And then some people do it for
so
IV.
moderate sedation, the consumer, that's what they're calling twilight sleep.
I think there's a big
But you don't
confusion
like that
even among. Well, I think there's a big confusion among dentists and people. They think sedation means asleep, and I think some dentists here have said, "Oh, do you do sedation?" And I say, "Yeah," and ask them where they do it, and they say, "Oh, we go to a surgery center." So there's still some confusion with the terminology, and I think it's unfortunate because in our specialty training, this is the way you're trained to talk about it. That creates a lot of confusion, I think, for people when, yes, I offer sedation, but I also can go to the hospital and offer general anesthesia. They're two different things. One's asleep and one's not.
So would it be smart to say mild sedation is nitrous oxide, moderate sedation is done in the dental office, and general sedation is done in the hospital?
Correct. So, yeah, there's different levels, and the problem is, there's overlap between the levels.
Right.
So, you as a general rule, you obviously want to look at what your state will allow you to do as your dental board and what you're trained to do, but you always want to be able to rescue someone from one stage deeper than you're able to take them. And that's what I was taught in my anesthesia rotation at UNLV. And, if someone's going deeper than you're trained to do, that's not something that you need to have a corrective action. That's not something that you want to be doing. So the biggest thing I think from a sedation aspect is staying within what you're trained to do. And, if you're not trained to do it, don't do it. You don't want to be getting into trouble.
And when you do the general sedation in the hospital, do you do the sedation or do you bring in a board certified anesthesiologist?
Nope. So all the stuff at the hospital is done by either an anesthesiologist or a certified nurse anesthetist. So I don't do anything as far as putting them to sleep. They manage the airway. They put a breathing tube in, all that stuff. If they need me to stop, reposition, do anything, I get out of the way and they do that. Number one priority at that point is, the patient's airway and, our obviously heart rate and things like that. But
I'm gonna ask you a very politically incorrect question. You don't have to answer. Is there any advantage or disadvantage of having an MD board certified anesthesiologist or a nurse anesthetist when you're in the hospital?
One of the things that I've noticed is the comfort level of the training. So there's certain kids with special health care needs that my hospital would not feel comfortable working with. So that's something where that may have to go to, a university setting just because the kid's metabolism, they have a metabolic disorder, things like that require, a little more training, maybe something that they're not comfortable with. But at the same time, if they're comfortable with the case, the only person that can clear a person for general anesthesia is the person doing it. So if that person feels that within their training that they're qualified to manage this case, and that's their choice.
So you do you use both? Do you use MDs and nurse anesthetist?
I've used MDs before, and then here at the hospital we have certified nurse anesthetists, and they do a wonderful job. They do, manage the kids pretty well.
Well, hey, we are out of time. My format is an hour, and we're at an hour and 3 minutes. I just want to say, dude, I think you're so cool. I'm a big fan of your course. You got to see the blunderbuss apex in search of a smoking gun. I'm a big fan of your 400 posts. I can't believe you're just a kid and you've already got a CE course. You got all these posts. You're in organized dentistry. Seriously, thank you so much for your passion, your enthusiasm, and for all that you've done for dentistry in such a short time.
Well, I hope I can only grow. I want to, if we're not involved in it, someone else will be, and I want to be here at the forefront and of the issues. I want to, be involved in our communities, and I really appreciate you reaching out to me and having me on here. It was a heck of a fun time putting together the CE course, and it's just a wonderful thing to help educate people. And I hope if you take it, I hope you learn something, and I hope you can take something into your practice every day that really can help you build and grow your practice and feel more comfortable managing some of the cases that I learned in my residency training to treat.
And I think I'm looking at a future president of the American Dental
Oh,
Association some
I
way.
don't think so. I think that'd
Oh,
be
I don't
too
know.
much work.
Well, you might think differently when you're my age, but and if you could send me an email and introduce me to those two Delta ladies, I'd love to do a podcast or an article or something on that Delta. And
Yeah, I'd
I'm
be happy to.
very curious
I'll
if
send you them and also my contact at the University of Iowa that would love to talk to you about the program. I think it'd be a great way to maybe get it started in another state. And, it's a great way for dentists that are coming out of school to take a huge chunk out of their debt load if they're able to work with it. So I think it's a great thing that we can share, get information out, and hopefully get it started in a few more states.
All right, buddy. Well, thanks again for spending an hour with me.
All right, thanks for having me. Enjoy
Thanks,
the rest of
Jarod
your day.
Johnson. Bye bye.